May I request the chairpersons to invite the next speaker, please? Hello. May I request the chairperson to introduce the next speaker?
May I have the privilege of introducing the speakers. Dr. Jasmeet Singh is MS MCH pediatric surgeon. He is one of the best pediatric surgeons in Pune. He has more than 24 years of clinical experience. Dr. Jasmeet Singh is also specialized in endoscopic pediatric surgery. Dr. Jasmeet Singh has conducted more than 100 camps for children in and around Pune and has performed many free pediatric surgeries. Renowned for their meticulous attention to detail, precise diagnosis and compassionate patient care, this surgeon has successfully managed a multitude of intricate medical cases.
Thank you for that kind introduction. So at the outset, I'd like to thank the organizers for giving me this opportunity to talk on a subject which is rather close to my heart. As you will realize, the long-term implications of hyperspeed sexual life are plenty. And it starts off, the story really starts why this lecture was conceived. It's basically the knowledge and awareness. It changes our perspective and approach to all problems, and hypospadias is one of them. So we start out with some kind of a knowledge of the past, which was how we thought or how we approached it then and how we approach it now. So there's always a then and now in everything that we do. So you can see our college, PG Medical, then and now. My training also at JJ, so Grand Medical College, Bombay, how it was then and how it is now. I work in Jahangir, how it was earlier and what it is today. I work in Surya, I'm a director there, how we started off and what it is today. So, coming to the perspective, So what is the disease burden of hypospadias and what is its relevance for this audience? It is not detected on antenatal ultrasound. So the incidence is always going to remain high. So none of these babies are ever going to get terminated. So many more are going to be operated in the future. Every year, at least about 1 lakh of patients are born with hypospadias in our country. So you can imagine the disease burden. Not all of them land up with problems. I'll come to that perspective soon. So, but we have to be prepared for the burgeoning psychosocial disease burden. And that is really where the most important role of the sexologist is going to be needed. So, incidence of hypospadias is so common. I've since 1991, when I started this practice of hypospadiology. So I've done more than 3,000 cases, and each case is meticulously documented and followed up. And now when I see those patients who have become adults and they're bringing in their own children and their relatives for surgery, you know that something which you did was right and something which you did wasn't really right. So what I'm presenting today is my learnings from the last 33 years of hypospadiology. So in which situation is the role of the sexologist really required? So we have cases coming to us even today, that adolescents and adults who haven't been operated even till today. So they've been passing urine abnormally, they have cordy, they are unable to perform sexual intercourse and land up with a whole lot of problems. Or the second category is where the patient has been operated in childhood, but the cosmetic result is so poor that they're generally not very proud of their penis. Or during surgery, some misadventure happened and there was a damage to the neurovascular bundle. So that leads to a poor sexual sensation or classically erectile dysfunction. And they do manage to develop a poor sexual drive due to psychological problems that I'm not a normal child. So that can also lead to gender dysphoria and disorder of sexual differentiation. I was very impressed by Tony Mundy when he had published a paper. It was mainly on the cosmetic appearance of the penis after hypospadias has been operated. So operated in children, and when they came to him, he's an adult urologist in the UK. So when they came to him, what problems he found, and he published a paper on that, and I was very happy to see that. So having read that, I had done my own survey of some 25 net savvy patients. I said, what would you expect from your doctor on hypospadia? They said, do it in a single operation, make it look as normal as possible, make it functionally competent, and the child should be able to pee in the public toilet without any hesitation or shame. I thought that there was a lot more happening there than just the cosmetic part of the surgery. And when I started the field of hypospadiology, I had identified 56 different aspects that we need to look at in hypospadia surgery, out of which maybe one or two I'll be touching upon today. So cosmetically pleasing has to be to the patient as well as the onlooker, who is going to be the partner in the future, parents initially. As close as normal, the glans, the meatus on the glans, the shaft, the amount of skin that is there, the diameter, all form a very, very important part of the cosmetic look. Then there has to be a good spongiosum cover over the urethra. When I started hypospadiology, there was no concept that the corpus spongiosum could be used. It was always thought that that is cordy tissue and that used to be excised. Whereas now we try and preserve every bit of corpus spongiosum, because that gives a very good support to the urethra below, and it allows the skin on top of the spongiosum to slide very easily during sexual intercourse. Then there should not be any cordy torsion, no scars, and it should happen in a single operation. So the cosmetic and functional correctness of the penis, all these things were coming into that category. And most of those procedures which were available in the early 90s were lacking in any of these. Hypospadias, as we know, has a wide spectrum. It can be very mild to very moderate. If you just broadly divide them into distal hypospadias with a good sized penis, generally you will always have good results, maybe 1, 2 or multiple surgeries if the person is not very competent. Proximal hypospadias, which has a small phallus, these are the ones where inadequacies will happen and they will show up later on in life, and those are the patients who need help from you. Single stage generally gives very good results. Multiple stages usually gives unsatisfactory results. So the endeavor has to be to try and master single stage repairs. When should we operate? 6 months is the best time. The patient has not yet started crawling. Patient is just used to lying down in bed. That's the best time. Maximally should be operated till 18 months of age, because genital awareness starts at 18 months. So the minute the patient starts understanding that I've got something wrong with me, your pattern is already started. And the role that a psychologist will have to play in the future of the child will be very, very important. But we know the patients come at any age. I get so many adults also today. Main thing should be able to be standing up. So, Ormond Culp in 51 had said it's the inalienable right of every boy to be a pointer than a sitter. And it has a lot more that the meaning. This is just to show you some examples. Distal hypospadias, you do the surgery, you get very good cosmetic result. Here shows you that the patient has become an adult over here. It's not seen over there. And even the adult phallus looks pretty good. This patient should not have any problem. Another distal hypospadias, you can see excellent long-term follow-up result. Another distal hypospadias, again very good long-term result. The patient has become an adult over here. So to show you that. Distal hypospadias, again long-term follow-up, you can see a very good result. But many of the cases that I do are redo hypospadias. Many of them come looking grotesque. This is a hypospadias cripple. The term hypospadias cripple was born because of this. Of course, we don't call them cripples because that is again telling them something. You're suggesting to them that you are a cripple. So we don't use that word, we don't put it into writing. We call it complex redo hypospadias repairs. Here you can see another complex redo repair, but these can also be done and corrected as best as possible, as you can see in this particular patient. Yeah, you can see this hypospadias cripple, and even after surgery, we're able to repair him to a good level. Here you can see this particular complex redo hypospadias. That was the immediate result, and this is a long-term result. Here you can see another one, again botched up case, but corrected. This was done in 2002, and you can see that this patient, after growing up, is looking pretty much normal. Another one looks grotesque. You can see that this is called as the shawl scrotum. The scrotum is above the phallus, and that is called as a penoscrotal transposition. So that can also be corrected, and you can get a very good result. Penoscrotal hypospadia, you can see that the meatus is down here. Again, you can get very good long-term results. When you say good long-term results, you need a minimum of 2 inches, which is required for satisfactory sexual life. So this is one such example. Surgically, we cannot increase the size of the penis. That's extremely important to understand. Okay? We cannot increase the length of the penis. The tissues can be reconfigured to restore the penile shape or the size, but you cannot elongate the penis. So whatever nature has given you, we have to work with that. Here you can see again shawl scrotum or penoscrotal transposition, bifid scrotum. It was a perineal hypospadia, single stage surgery done. This was the immediate post-op result, and this is a long-term result. Maybe slightly shorter phallus. This is a non-erect, of course, but very, very satisfactory result as far as the patient is concerned. There are many objective assessment methods when we are trying to assess our hypospadias repairs. So one is called the pediatric penile perception score. The response rate to these scores is very, very less, but 80% of them find it acceptable functional cosmetic sexual outcome. That means there is still a 20% population of operated patients who are not satisfied, and they are the ones who develop a whole lot of problems. Multiple studies which concluded exactly the same thing, different ways of assessing them: decision regret scale, pediatric penile perception score, sexual quality of life in a male, international index of erectile function. I don't need to go into the detail, but that is how we assess that. So the long-term sexual outcomes of hypospadias surgery, which are often overlooked, are these ones: erectile dysfunction, ejaculatory difficulties, sexual sensation, lower self-esteem, teasing amongst peers, and a very negative genital perception. And these are the cases which must be referred to sexologists. We have not been paying attention to this category of assessment of the patient. And as hypospadiologists, as we interact more with you people, we are going on increasing that awareness. Even in ugly skin like this, patients are not happy. They come to me and then I've had to revise these patients. They've been operated earlier. Even if the glance looks ugly, the sutures have given way, patients are not happy. They come for correction. So that means something is troubling them, and that's the reason why they're coming for correction. There is a particular way in which the glance should be sutured, so you do not get any cosmetically bad results or scars of your sutures. And this is one patient who demonstrated the screen just as I was about to take a photograph. You can see a very, very good stream. Some unknown thing, nobody ever paid attention. One was deviation of the median raphe. And the median raphe sometimes goes to the right, sometimes goes to the left, and that leads to torsion of the penis. So these also need to be corrected. So that brought in the concept which I introduced of independent mobility of each and every tissue. Only then you can correct something like a torsion. So many publications and many dissertations later, all these various surgeries were formulated. Whole idea being that we should be able to restore as normal an anatomy as possible. Sometimes you get patient referred, you really don't know what surgery has been done earlier, and yet you have to give off proper results. Sometimes you get very, very severe chordae, and the chordae can be, you can see this is deviated to the right side. So these are called as lateral chordae. Classic chordae is ventral. Just 1 minute. Okay, so these can also be corrected. This is now mild residual torsion. Mild residual torsion, somehow the patients don't seem to be really far affected by that. Mild chordae also, they are not too badly affected by that. What really affects them, but if you have a severe residual chordae, like in this particular patient, they're definitely affected by that and they come for correction. If the scrotum doesn't look normal, like this is a hemiscrotum, and the patient also had an undescended testis, so I had to literally create a kind of a scrotum and put that testes into the perineum. Restoration of normal anatomy procedure, which I introduced, gives excellent cosmetic results, both short term as well as long term. So, in my series, I found the residual chordae in about 3% patients, and on some pretext or the other, fistula or myelostenosis, the patient needed reoperation in about 20% of the patient. But we have always been assessing the cosmetic result. So satisfactory was 95, unsatisfactory was 5%. But the problem which we have always ignored was the functional result, psychosocial result, and the sexual prowess. So any such problem, I think it has to be referred to a sexologist, and that's where your role comes in. Thank you. Any time for questions or the time? Oh, thank you.
May I now introduce the next speaker, Dr. Shashank Shah. Dr. Shah has done illustrious service FAIS, FICS, honorary FIAGES, honorary FMAS, honorary FMPS, honorary FALS, diploma is visiting professor, IRGAD France, partner Lapro Obisco Center, Pune, consultant PD India, Mumbai, honorary consultant, Lelavati Hospital, Mumbai, publications, 25 in index journals, presentations, many national and international. BBL Fonseca Scholar Award by American Diabetes Association. He is the first surgeon to have his biography printed in the Obesity Surgery Journal of International Federation of Obesity Surgery, IFSO. World Book of Records, highest weight loss in the heaviest Indian women. Limca Book of Record, surgery on heaviest woman. India Book of Records, maximum weight loss after bariatric surgery. 45 hernia surgeries in just 10 hours, published by Limca Book of Record. IFSO Award of Appreciation for great contribution to the growth of the Federation. His areas of interest include laparoscopic and metabolic surgery, hernia surgery, thoracoscopic thymectomy, general and laparoscopic surgery.
Thank you, sir, for the kind introduction. Good afternoon, everyone, and let me first thank the organizers, especially Dr. Rajendra Sathe, for this kind invitation. And I'm going to talk about obesity, metabolism, endocrine disorder, and maybe in a different crowd, I'm going to give some introduction about how obesity develops in an individual. It's been almost 21 years that I'm doing bariatric procedures, more than 15,000 procedures. I'm happy that the unit we started is ranked among the top 4 in the country and first in West in India. We have the best clinical research on surgical reversal of diabetes by metabolic and bariatric surgery, which received the best award from the American Diabetes Association, and that's now in the algorithm of treatment of diabetes. Now, giving you an example of a landmark case, a lady came to us 300 kg, obviously zero sexual function, bedridden. You can see the transformation. She lost 215 kilograms. She's up and about. She started looking for a partner. So this kind of sexual transformation can be possible in patients with morbid obesity, and they received the World Book and Limca Book of Record for highest weight loss at the end of 5 years. She lost 215 kilograms. Now, everyone thinks that by eating less and exercising more, one can easily lose weight. But that's a myth. The American Diabetes Association defined obesity as a disease and not just a lifestyle disorder. This is an experiment in rats where rats were forcefully overfed, and you can see that they were left to the environment, everyone lost weight and came to normal again. But this doesn't happen in human beings. The biology is very accurate, but we definitely see some people obese and some thin. These are real brothers, same blood group, same mother, same environment. One is struggling to lose weight and one is struggling to gain weight. And this itself clearly described that it's a disease, something beyond what we think. We always try and think, even before I started bariatric surgery, I used to think that by eating less, by exercising, someone can lose weight because we used to always apply physics. But if you apply physiology to physics, the metabolism is totally different. And I'm going to take you quickly through the physiology of GI tract, which is interlinked with endocrine system and eventually the sexual system. So initially a surgeon thought that if you cut the stomach into a small stomach, patients will lose weight, so he cut the stomach horizontally into a small stomach. No one lost weight. He was surprised. Later, when the stomach was vertically divided into a smaller stomach, same size, everyone lost weight. And then it was understood that it's probably the curvature of the stomach which is responsible for weight gain. The curvature secretes a hormone called ghrelin, which is an obesogenic and diabetogenic hormone. So unless that hormone comes down, person's hunger satiety doesn't go down, he will feel hungry and the weight will still continue to increase. So we pioneered sleep gastrectomy way back in 2002 and did all the clinical research in sleep gastrectomy. I am quickly going to show you a small video as it runs. Anyway, the technology, can you make the video run? The technology is very advanced, automated suturing devices, 22 minutes procedure, patient starts walking in 2 hours and next day the patient can go home and the acceptance is more because of that. Can you believe? Now I talked about ghrelin. Ghrelin is a hunger hormone secreted by stomach. But ghrelin expression is also linked with secretion of testosterone. If there is excess ghrelin, the testosterone goes down and then sexual function can go down. This is how we started sleep gastrectomy way back. This is called enteroinsular axis. Whenever food reaches the last part of ileum, there are L-type endocrine cells which secrete GLP-1, PYY. So GLP-1 and PYY accelerate metabolism, reduce appetite, increase satiety, improve pancreatic secretion, and therefore any procedure that can connect a shortcut between stomach to intestine will lead to reversal of diabetes or weight loss. And I'm going to tell you something interesting. Now this GLP-1 secreted by the last part of ileum also has anti-inflammatory, anti-fibrotic effect on the gonads and endometrium, and that is how they are affected in obesity and diabetes. All these patients with morbid obesity, severe obesity and diabetes have relative deficiency of GLP-1. Now this is an interesting study. We tried to see the total small bowel length of people who were thin and people who were obese and tried to see the speed of transit of food from ileum to from jejunum to the ileum, and we found that in thin people the transit of food is faster and the length of intestine is longer. That means food absorption is higher, there is relative deficiency of GLP-1, that means it is involuntary, no one can control, just like a height, bowel length and function can be different. And therefore, any procedure which can create a connection between the duodenum to jejunum will rapidly take the food, it will be relative shortening or normalization of intestinal length, stimulation of GLP-1 and reversal of diabetes, obesity and improvement in sexual function, and there are multiple such hormones which are interlinked with the endocrine system as well as the sexual function. Now coming to this picture, patient came to us, underwent bariatric surgery and then he sent this photograph. Indirect evidence that his relationship with his wife improved. Needless to say, if you say someone like this and he comes to a sexologist, there is nothing else other than bariatric surgery because his penis is totally buried, physically impossible. Bariatric surgery improves sexual function by weight loss, improvement in hypertension, reversal of diabetes, reversal of sleep apnea, increase in testosterone, improved psychology, reduced depression, improvement in dyslipidemia, reduction in central obesity, resolution of metabolic syndrome. And bariatric surgery can improve sexual function, sexual desire, sexual intercourse satisfaction as well as total satisfaction and overall self-confidence. There are multiple papers which show that as on today, almost half of obese people may present with lower than normal testosterone. Low testosterone is actually a cardiac marker. Just low testosterone and sexual markers is equivalent to a cardiac marker. Impact of low testosterone has impact on low physical activity, on impaired psychological health, and there are multiple papers shown that patients' compliance commitment can go down. Low testosterone gives rise to lack of confidence, lack of compliance, reduced fertility, sleep apnea, reduced metabolic rate, fatigue, poor focus, mood differentiation, depression, psychological impact, low sex drive, erectile dysfunction, sarcopenia, eventually can give rise to metabolic syndrome, diabetes, and poor quality of life. So we did a study in young patients who came to us for morbid obesity and bariatric surgery, and we were surprised the incidence of low testosterone was as high as 81%. Almost 19% of those boys had normal testosterone. If this is not treated, probably will give rise to sexual dysfunction, marital problems, depression and other problems. As you all know, obesity has aromatase which converts testosterone into estradiol. Obesity is an inflammatory disorder. It increases inflammatory markers, eventually reducing the gonadotrophic secretion, further reducing testosterone. Adipocyte dysfunction, insulin resistance, everything will eventually lead to reduced testosterone and affection of sexual function. This is a picture, but gynecomastia, we see gynecomastia in worsening their psychological health. Pseudo-hypogonadism, they don't speak about it, but it's a challenge and it's a buried penis only purely because of obesity as well as low testosterone, reduced secondary sexual character, fatigue, failure to comply to advice, diet advice, exercise advice, and the gynecomastia seen in boys was so big that even after losing weight they needed surgical correction. So these patients should be evaluated for testosterone in time. This is, you can see clinical there. Pseudo-hypogonadism. I am not saying hypogonadism. It's pseudo-hypogonadism secondary to obesity. Now, the new thought process is testosterone of 300 is not enough. If you look at the age-specific middle tertile, it should be almost 500. Young boys are supposed to have high testosterone and just a low normal testosterone is borderline passing, so they need to be treated. This is one boy treated 15 years back truly for hypogonadism secondary to low testosterone diabetes, and you can see the boy. This is recorded by BBC in a document. This is another gentleman, needless to say, his sexual function was totally disturbed. Sleep apnea is another one which can give rise to hypoxia, hypercarbia, hypertension, reduced libido, increased cardiac risk, and sleep apnea's action is attributed to neural and endothelial impairment, giving rise to sexual dysfunction, and it can be reversed with metabolic and bariatric surgery. And this gentleman who was always living in a day, night, buried penis, almost the reason for divorce was sexual dysfunction, and you can see his life is restored and he is getting married again. This is another such example. So low testosterone is now one of the important indications for offering bariatric surgery apart from just the excess weight. So sexual dysfunction due to low testosterone in morbid obesity is an indication. Obesity can induce sexual dysfunction with various actions. Hormonal imbalance, as I said earlier, restricted blood flow, excess weight can restrict blood flow to genitals, making it harder to achieve organisms, psychological factors, chronic inflammation which can give rise to endothelial dysfunction, and many other factors. Now it's not only obesity, diabetes, but there are many unspoken problems. Acanthosis, fungal infection in groin, sweating, odor, difficulty in maintaining hygiene because of the size, painful joints, painful posture during sexual function, reduced self-esteem. All these together make them lose their confidence in sexual activity, and this is one of the main reasons for sexual dysfunction. Bariatric surgery seems to reduce the risk of sexual dysfunction, and it's directly correlated with loss of BMI. Another important comorbidity which is induced by obesity is urine incontinence. Whenever someone has urine incontinence, they seek advice from a gynecologist or a urosurgeon, but it's purely because of increased intra-abdominal pressure, giving rise to pressure on the valves. And urine incontinence can negatively impact sexual life of a person. This is another example. This lady could not have a contact because severe urine incontinence, and urologist said there was no abnormality in the anatomy. Just bariatric surgery, rapid weight loss, reduce intra-abdominal pressure can resolve their incontinence and restore their life. These are few examples. Severe incontinence, almost loss of libido, and now she is restored and maybe can think of getting married. This is a married lady who had severe abdominal obesity giving rise to urine incontinence and was treated. There are other problems as well. Pain in the hip joint, pain in the pelvis, pain in the knee joint, extreme difficulty in achieving any posture for sexual function, and they can be easily treated. You can see this lady, no joint replacement has been done. The last photograph is after 8 years after procedure, and in the first one she looks older, the last one she looks younger. This is a true example. Now there are n number of young ladies who go for IVF because of obesity, infertility, polycystic ovarian syndrome, hyperinsulinemia, and then she underwent bariatric surgery, conceived. When I asked her after a few years, she said, "Doctor, there was no PCOD, insulin resistance as a cause. My husband never came close to me. We came close to each other only after bariatric surgery. So sexual dysfunction was truly the cause where we led into PCOS and hyperinsulinemia. And the beauty is after her second delivery, she underwent second stage procedure, and you can see Anna, again a young lady, after second stage bariatric procedure, which it can be done. The real transformation and improvement in sexual health you can see in this picture. This lady came to me, underwent bariatric surgery, and this young girl came to me after 3 years and I practically could not identify. This one, again another example, she underwent treatment for diabetes, but you can see her attraction, sexual function has totally improved. Different procedures have different results. Bariatric surgery improves hypogonadism in male. Bariatric surgery has favorable effect on levels of testosterone as well as sexual performance. Bariatric surgery increases total testosterone, free testosterone, LH, FSH, SHBG, and level of estradiol increase, therefore improving the sexual function. Of course, robust increase in testosterone only seen after bariatric procedure. So in short, those with morbid obesity, diabetes, metabolic syndrome, and sexual dysfunction, the hormonal imbalance is induced by severe obesity, and it can be totally reversed, which cannot be done by any other therapy alone. Of course, bariatric surgery combined with multidisciplinary action with psychologists, dietitian, and sexologist can give the best life to the patient. Thank you so much.
We will take after.
बंद कर
Dr.
यश
Pankaj Joshi,
बंद कर ऑफ
our third speaker of the session. Third speaker.
Hello. Since 9 years in reconstructive urology. He has won multiple awards. He has more than 35 publications, 6 book chapters to his credit. He has been a national and international faculty, delivering lectures and performing live university workshops. Dr. Pankaj Joshi was awarded H.S. Bhatt Gold Medal for standing first in urology exams throughout the country in 2010. Over to Dr.
Thank you so much for this kind introduction. I thank Dr. Sathe, Dr. Mudha, Dr. Roshita Kare, and I think it's a great meeting. We help people have sex, but I never realized there's a meeting called SexCon completely dedicated to it. So thank you for introducing me here. And this is my job. Sandesh is my colleague, and this is what we do. We empower people to have erection at will and at wish. And when it doesn't happen, this is the solution to it, that we do a benign prosthesis. So we all have tried Viagra, we all have tried tadalafil. When it doesn't work, there are patients who have priapism, fibrotic corpora, and way back in 1960s it started that we put a prosthesis inside the penis and then have an ability to have sex where mind is taken away, the natural reaction and forces are taken away. The first prosthesis was made way back in 1967, and there were two types. One is a rigid prosthesis, where the patient, or I would rather than saying a patient, the man has an erection all the time, and he can do the activity. I had a patient who had sex 37 times in a day after putting a penile prosthesis, and they actually text you. And there are prostheses where there is a button, and just by pressing the button you get an erection, and after the act you press another button and the erection goes away. So penile implant is very vast. I divided it into two categories: inflatable or malleable, with something called as a 2-piece and a 3-piece, looks like clothes actually. And then we have various companies like AMS, which makes 700, Infla, Titan Mentor, And one we have prosthesis which is with memory, it's called as a tube, and without memory is an Indian penile implant. I would like to state that we have Dr. Rupin Shah. I'm sure many of you must have heard his name, and his penile prosthesis is the most widely used prosthesis across the world, and it is a very versatile prosthesis. So malleable penile implant cost anywhere between 20,000 to 1 lakh rupees, surgical cost excluded, while a 3-piece implant would cost between 7 to 10 lakhs. So that is a huge difference in the cost. And these are the various malleable implants we have. We have the Shah's implant, the Tactra, the Zephyr, the Vegetarian Tube. And I would like to say that the Shah's implant came in 2008, while all other implants are much relatively new. It's the most versatile. And we always try what is called as the bending cycles. So this implant can last up to 1 lakh bending cycles. There's something called Shore where they measure the pressure the implant is going to put on the vagina. And all these things are very important when it comes to placement of an implant. When it comes to inflatable implants, it's more like having a Merc or an Audi car. We have the 2-piece which has 2 connections. I'm going to show you 2 short clips. So I'm going to empower you to put an implant or send your patient to me so that I can put an implant or my colleagues can put. We have the AMS which can hold up to 65 to 100 ml reservoir. We have the Coloplast which can hold up to 125 ml of water. And we have the Rigicon and the ZSI implants. So this is what we do typically in a Shah's implant. I hope the video is going to play. And we have a patient who is prepared, painted, draped. This is only a 3-minute clip. We mark about 8 centimeters from the glans. I'm going to make a transverse incision. All my patients are after pelvic fracture. So after a pelvic fracture, they get an erectile dysfunction. So we have done a urethral repair. We do the largest urethroplasties in the world at Europol in Pune. And we have operated in more than 51 countries. So we have a pool of more than 2,000 patients of pelvic fracture. So what I am doing is I am dilating the corpora. So these are the female Hagar's dilators. So we dilate the corpora. We have to make a space into the corporal tissue. And we dilate it almost up to 30 French. So basically the principle of a penile implant is there are 2 corporal cylinders in which you put these implants. These implants are made up of silicone. This is a surgical procedure which lasts about 40 minutes. I have finished the dilatation of the right hand side of the patient. Now I am going to dilate the left hand side of the corpora, and then we measure what is the total length of the tissue. And this is how the implants are. It has a bendable part which is in the center, and it has a tip which is very rigid. So once I put the implant inside, the penis will have a constant state of erection. This is a Shah's implant, which is a simplified silicone. It's made by Surgiware. It's made in Shahjahanpur in Uttar Pradesh. And we just twist the implant and placed it into the corpora. This procedure takes about 1 hour. We keep a catheter for a day. The patient is discharged on the next post-operative day. And usually we wait for a period of 6 weeks because it will form a capsule around the implant, and then he is able to perform a sexual activity. So from a state where they've never had an erection, especially for post-pelvic fracture or post-priapism, sickle cell anemia, and we have a large chunk of patients in the Saudi Arabia and the Middle East now increasing. I have a patient on whom I put an implant at the age 75. So if you think that people are not interested in sex after an age, that's a wrong notion. And this is how the penis will remain erect after a particular surgery. My second implant, again a very short video, is a 3-piece penile implant. So this is where rather than having an erection for a continuous time, we go to empower the patient or his partner to get an erection. So the initial steps are the same. We have to dilate the corpora. There's not a lot of blood loss because these are all fibrotic corporas. They are not used for a long period of time. The only precaution we take is we stop clopidogrel, because if the clopidogrel is on, then there can be an impact on the hematoma formation. So we keep on dilating it till we reach the mid-glans. The skill is in the dilating the corpora. You won't believe me, but a priapism penis after sickle cell is as hard as a wood. and as hard as a stone. So we have actually drills for drilling a hole into the corpora. It's like a mechanical instrument which has got multiple serrations. This is a measuring cylinder that we use, so we know the distal and the proximal length of the corpora. Lots of antibiotic is flushed because this is and this is how the implant looks. There are two cylinders there and there is a reservoir which is there. So I make a small abdominal incision. I'm going to put a reservoir which will hold 125 ml of water. So this is your base, this is the water base. Then there are tubings, and now these are the implants actually. So I'm putting the cylinders inside the corpora. This is a needle which helps me use a thread, and with the help of a thread I'm going to put the implants inside the corporal cylinders. So this device is called as a furlough, and as I was telling, this implant cost around 8 lakh rupees. It's imported, and the design made in 1967 still holds true. So you have to be very careful when you push the cylinders because there are needles and sharp instruments around. You don't want to prick the cylinder. If you prick the cylinder, the surgery is gone. And this is how I've put water, 65 ml, and then there is a pump which is used by the patient or the partner. And once you pump, the water from the reservoir will go into the penis. He will get a rigid erection. And there is another button which is there at the top. After the sexual activity, you press the button and the erection goes away. So it is a very natural thing. To choose between a two-piece, there is a connection which needs to be made, which is done by a quick connect. Whether you choose two-piece or three-piece is technically today on affordability. But once insurance covers it, I'm sure everyone is going to go in for a three-piece device because you don't have to be erect all the time. So this was just quick recap of what we did. So the patients we have are the ones we have refractory ED which come after you all treat the patient. When they can't get an erection, they come to us. We have a lot of transgender surgeries happening where we do a neophallus, a penis made out of hand or a lat dorsi tissue, and it is flaccid. So we put in prosthesis, gender reassignment. Hypospadias patients want a longer penis, so there's a technique where we make. Jasmeet Singh sir is the pioneer in hypospadiology, but we can make multiple incisions and we give them an implant so they have a longer penis. Priapism, complicated diseases, and of course obesity whenever sir treats. And when they have an erectile dysfunction, many a times we have to put an implant. I really thank for this invitation, and I'm sure Dr. Sathe, Khare and Dr. Amit Mutha have done a wonderful job, and I hope I was able to give you little surgical insight and what we can do to make a person erect. Thank you so much.
Now I would like to, I would request to our chairpersons to facilitate all our speakers of this particular session. I would like to invite Dr. Jasmeet Singh, Dr. Shashank Shah and Dr. Pankaj Joshi on stage for felicitation. It's okay. Okay. Take it up. What? उठला नहीं Now I would like to. Yes, sir. Now I would like to invite Dr. Sudhakar Petkar to felicitate our chairperson. Please remain on stage for a minute.
यश कसं होतं व्हिडिओ मला
Now I would like to invite our chairpersons for the next session, Dr. Sonali Mutha and Dr. Kalpana Hirande on stage and introduce our speakers.
इकडे हे यश तर लगेच उठून गे मी त्याला म्हणतो अरे बघितलं असतं आपण कधी पण बाहेर आपल्याला अरे ए ऐक ना आवाज जात नाही ना लाईव्ह स्क्रीनला माझा आवाज जातं उगाच काही पण माईकचं इथं आहे
Hello.
Hello. It's nice to introduce my friend Dr. Alithia Babai. She is obstetrician and gynecologist with over 20 years of experience. She is a director at Toral and attached at Psychiatry Hospital. Known for her expertise in compassionate care, she provides exceptional healthcare services to women.
Thank you. At the outset, I would like to thank the organizers, especially Dr. Amit, who's also been a very dear friend. Thank you for this opportunity. I know it's been a long day and I don't think I'll be boring. I think I'll do a quick talk. I'll be discussing on vaginismus from the gynec point of view. I'm sure we all are very well versed with this topic. So basically, what is vaginismus? It is a psychosexual disorder. As we all know, that there is a considerable psychological aspect to vaginismus rather than mainly an organic cause. And it is associated with the difficulty and pain associated with vaginal insertions, whether it's during sexual contact or even inserting tampons. And its prevalence per se is around 1 to 6%, but this is highly underreported because of the social stigma and the cultural influences. In specialized centers, we see the incidence rate and prevalence as high as even 40%. So basically what happens in vaginismus is there is involuntary contractions of the levator ani or the pelvic muscles, which generally involve the levator ani. As you see, the red, purple and the pink one, these are the levator ani group of muscles, which is the pubococcygeus, the puborectalis and the ischiococcygis muscles. So during sexual arousal, when there is sympathetic and parasympathetic activity which causes vaginal congestion and increased vascularity, in patients with vaginismus, this sensory stimulus basically of fear and pain causes not the arousal but the involuntary spasm of the muscles causing withdrawal. So the main causes are, we have organic and psychosocial factors. Mainly in patients with vaginismus, more than organic, we see the psychosocial factors getting play in these kind of disorders. Organic causes we generally see in patients who have more of dyspareunia rather than vaginismus. So organic causes, we have abnormalities of the female genital tract, trauma during childbirth, vaginal dryness related to breastfeeding, menopause. Then we have endometriosis, which is really on the rise in the current scenario, vaginal irritations, vestibulodynias. Psychosocial factors, these are very, very important, and these are the core cause of vaginismus. One is any physical or sexual trauma or abuse, very, very common. Very difficult to elicit in the history in patients with vaginismus because of the cultural taboo. Also, religious and sexual strict upbringing. They don't even talk about sexual health in families, or even negative inputs from their peers or from their maternal influences, where they have spoken about bad experiences, which then triggers for pain and fear during sexual contact. So what is the main clinical presentation? Generally the couple will present with having pain during sexual intercourse, and they complain main sentences, I feel as if my husband is hitting a brick wall, or there is no hole down there. This is commonly what we hear. And they are not able to tolerate tampon insertions or even fingering. They have not consummated marriages. They have lack of lubrication and lack of sexual desire. And we generally see these girls who are very nervous, lot of anxiety, hysteria, and they sometimes are not even able to describe their own emotions. Differential diagnosis from vaginismus is, of course, we can't label everybody with vaginismus with the inability to have a consummated marriage. So one is dyspareunia, as I said, where how do you differentiate between the two? Dyspareunia is also painful penetration, but dyspareunia, there is pain and fear associated before, during and even after sexual contact. And your sexual contact is possible, penetration is possible. Here the patient generally complains of, I have a burning pain after sexual contact or during penetration. This is how you differentiate. And the degree of fear, anxiety or the muscle tension is far less as compared to vaginismus. And vulvovestibulodynia is basically pain that is associated with the opening around the vaginal opening and involving the labia minora and the majora. So here the assessment here, of course, is careful history taking. Here it is very, very important to give the patient adequate time. You cannot have a busy running OPD and give the patient only a minute. You need to have a very, very patient ear. You have to hear the patient out, and then only will the patient agree to a clinical examination. Otherwise, she is going to walk out your door and not come back to you. So here, what we do generally is, of course, counseling. There are history-taking examination. Now, these patients are generally very resistant to examination. So we first counsel, we talk to the patient, make her at ease. Then if she is willing, we take her to the examination table. Here also the patient will ask you, what are you trying to do? What will you do? Very anxious. So we generally counsel them is, I will not touch you. Can you separate your labia for me to see? So, and in this situation, she will allow. So this way, I know whether it's an organic problem or whether it's a psychosocial problem, whether it requires surgical correction or whether it requires just counseling, physiotherapy, which will help her to get rid of this problem. Of course, there is a grading system. This can be found everywhere. So the lesser the grade, the easier it is and faster it is to correct. Higher the grade, they generally need more intensive therapy from physiotherapy, psychotherapy, cognitive therapy, to even vaginal dilatation or even sometimes botulinum toxin injections, which I'll explain later. So as I said, treatment in here, in most cases more than organic, it is psychosocial. So understanding the psychological factor and correcting that is more important than basically just treating the vaginismus. This is very important. And of course, it's a multidisciplinary team. No one person can do it. You need a psychologist, a physiotherapist, a sexologist, and a gynecologist. As I said, counseling, first explain the anatomy and physiology. What is the anatomy of the vulva, the vagina? What is where? Some people don't even know how to perform the act. Okay? And also, they are also told what is the protective role of these muscles. So when you explain to the patient about what is vaginismus, you tell her, okay, fine, we have muscles around the vagina and they contract and they're not in your control. Then she'll ask you questions like, then how do I control it? What is this? You know, why is it there? Why is it not allowing me to have intercourse? Then you can explain that. So these muscles also are not only for involuntary contractions, they don't do that, but they are also as a protective role that God has given to protect you from any harm that can be done in relation to the vulva. So this way she will understand better and she'll be more at ease. Then we explain the entire treatment procedure, what comes when, next step, how do you start, how do you finish, and how do you achieve the goal. Here specifically, I would prefer inviting the partner, so the partner also understands the situation and also relaxes her during the act. This is important because there are some men who feel that, as I said, it's a social stigma, where some men feel that they are overpowered and they try to be very rash and very rough, and then this worsens, this further worsens. So here it is important to involve the partner so he understands at every step when is he going to be allowed to perform. As I said, give time and constant reassurance. Also the patient has to be told that whenever she feels uncomfortable or she feels there is pain, I will stop. This is very, very important. You cannot go on. Gradual desensitization, like when she separates her vulva or her labia for me to examine, then we use a cotton tip swab or a cotton bud and we touch different areas and ask her, do you feel the pain? Are you comfortable? So in this way we know which are the sensitive areas and which are the sensitive points that need to be tackled. As I said, psychotherapy and cognitive behavioral therapy, they go hand in hand. This is absolutely essential for constant counseling. Pelvic physiotherapy is what we try first in these patients. We generally give it around 6 weeks to know how much is the progress. Here in Kegels, all of you must have heard about Kegels exercises. There we generally, like post-delivery, we say, contract, hold for a count of 10, relax, do this 10 times, 1 session, 3 sessions a day. But in vaginismus, we tell them, you need to focus more on contract and then relax. Sorry, 2 minutes now. Contract and then relax. This relaxation is more important than the contraction part while teaching the Kegels in these patients. Vaginal dilators are used. These help in serial dilatation. Once the patient reaches the largest dilator size, only then is sexual contact. We move to the next step where the husband is then allowed sexual contact. If nothing works, then the next step is the pharmacological therapy where we use local topical anesthetics. Generally, LOX 2% gel of the lignocaine is used, but nowadays better than that I prefer is Prilox. which is prilocaine. Prilocaine, I feel, is a better local anesthetic than even LOX. Then we use muscle relaxants like Botox injections, but this is like a last resort when nothing physiotherapy or even vaginal dilators, psychotherapy is not working. Then we use 2 botulinum toxin injections. Generally, they require only 1 shot. Okay, and specific areas which we deal with and we take into consideration are the muscle levator ani, as I said earlier. It doesn't cause incontinence. Like many would ask that if I'm relaxing the perineal muscle, would that cause incontinence of urine and feces? No. So it's specific areas only when the injection is given. So wherever we give the injection, it's only 2 centimeters around that area where the muscle relaxes. So it doesn't affect the continence. And as there is also psychological aspect, we sometimes use anxiolytic medication like citalopram. Last, worst comes worst, is then surgical management where we do hymenectomy. But hymenectomy, even despite hymenectomy, this vaginismus does not go. They still need all the other therapies for them to overcome this involuntary spasms. So when we do a hymenectomy, we also do something known as introital dilation to relax the perineal muscles. So it is important that we recognize it's a multidisciplinary approach and patient hearing, a lot of empathy, active listening, offer the patients even vaginismus groups where they talk to people and then they know they're not alone, support groups, give them good books to read, and hence by doing this, prioritizing this education, it helps us to deal with these patients of vaginismus and therefore help them lead healthier sexual relationships and overall well-being. Thank you.
Thank you, Dr. Aditya. Now I would like to invite our next speaker, Dr. Manvi Verma.
Hello. Our next speaker, Dr. Manvi Verma, is a cosmetic gynecologist and female sexologist. She has completed her MBBS and MD Obs-Gynae from GMC Jammu. She has done her PhD from NBE New Delhi. She has completed her MCH in cosmetic gynecology from AIMS Rishikesh. She is working as a consultant cosmetic gynecologist in Aesthetic Solutions Andheri, Motherhood Hospital Kharghar and Nest Hospital Thane. She is assistant professor and in charge cosmetic gynecology and female sexual problems, MGM Medical College and Hospital, Navi Mumbai. Welcome on the dais, Dr. Manvi Verma.
Thank you very much for the kind introduction, respected chairpersons. A very good evening to all. At the outset, I would like to thank the organizing team of this wonderful conference, especially Dr. Amit Mutha sir, for inviting me here. And I would like to thank the entire organizing committee to give me this opportunity. So my topic is impact of cosmetic gynecological procedures on sexual function and satisfaction. So I'm going to explore the relationship between cosmetic gynecological procedures and sexual function and to discuss the factors which influence the outcome of these procedures. But as I'm addressing a hall full of sexual medicine practitioners, so what is cosmetic gynecological procedure basically I'm referring to? So cosmetic gynecology basically includes all the procedures which are elective interventions, means there is no emergency to perform these procedures, which is done on the vulva and the vagina to improve the aesthetic appearance and the sexual function. So the point I want to bring in that these are done on basically normal genitalia. So what are the reasons for the increasing popularity of cosmetic gynecological procedures in this age? It is because of increased awareness. There's a lot of media exposure to the young generation these days. There are changing societal norms. So women, they are taking more responsibility for their own bodies, their own sexual pleasure. They are seeking treatment for the same. Then advancements in technology. There are a lot of non-invasive and minimally invasive options which are there to enhance sexual pleasure in women. Then social media influence. So, there's a lot of exposure to social media and explicit content, pornography. The young generation is too much exposed to all these, and accessibility and affordability. So it is very clear that the most important reason for asking for gynecological cosmetic surgery is the fact that women think that the surgery could improve their body image, sexual satisfaction and marital relationship. So it has been discovered that sexual satisfaction and genital self-image increased following female genital plastic or cosmetic surgery when the procedure was performed by a skilled surgeon. So let me just list the common cosmetic gynae procedures which are there. So number one and the most commonly performed procedure is labiaplasty. So labiaplasty involves altering the size and shape of the labia minora or the labia majora, and accordingly it is called as labia minoroplasty or labia majoroplasty. Then vaginoplasty, in which I am referring to vaginal tightening and not the creation of a neovagina. So it refers to the procedure which is done to reduce the size of the vaginal canal. Then clitoral hood reduction, it involves reducing the size of the hood of the clitoris. Hymenoplasty involves reconstructing the hymen, often for cultural or religious reasons. And perineal repair, which involves the surgery which is done typically after childbirth to repair the tears in the perineum. Okay, so this is just a diagram of a female vulva. Okay, never mind. So okay, the pointer is not working. Anyways, so this is just a diagram which is representing the normal female external genitalia. One by one, I am just going to list that what are the parts and how the female cosmetic genital surgery is going to impact the sexual function. So first of all, I am just starting from the left side, and the uppermost are the labia majora or the outer lips of the vagina or vulva. So this, the labia majora, the person who approaches for a labia majora correction usually approaches for a labia majora hypertrophy. So usually the component of female sexual function which is affected is the female sexual desire, because the patient feels that my labia majora are too hypertrophic or atrophic and I do not look attractive to my partner. So number two is the clitoris, which is the external organ which is made of sensitive tissue that can create feelings of pleasure. So this is the organ which is exclusively dedicated to sexual pleasure in females. So clitoral hood reduction is the procedure which is done to enhance sexual pleasure. Clitoral hood hypertrophy, if present, can lead to the obscure clitoris, in which the penis during sexual intercourse is not able to hit the clitoris. So the clitoral hood reduction, if performed by a skilled surgeon, can lead to the proper exposure of the clitoris during sexual activity and enhance sexual pleasure. Then number three is the labia minora. So the patients who report for a labia minora plasty usually have aesthetic or functional indications. So the aesthetic indications that the patient feels that the labia minora are too big or they are not appealing to the partner, and their hypertrophy means they are more than 2 cm in height. And the functional indications mean that the patient is not able to wear tight clothing. When she wears a tight swimsuit, she feels that her external genitalia or the labia minora and majora are visible through the tight clothing that she is wearing. Or even some patients have such hypertrophic labia minora that they can get caught in zippers. So that is really traumatic. And during activities like sports activities like horse riding, these labia minora, they are hypertrophic, they can interfere with the quality of life. So then there is the Bartholin glands, then mons pubis. So mons pubis is the area of fatty tissue covered with pubic hair. It is a typical organ which is The function is to provide cushion during sexual activity. So mons pubis can be hypertrophic or it can be hypertrophic and can be corrected accordingly. So then the urethra and the vaginal opening. So vaginoplasty is the most important procedure which is done for sexual enhancement. Mostly females after childbirth, they present with vaginal laxity and vaginal tightening surgery can be done to enhance vaginal sensation. Then the perineum, the area of the skin between the vulva and the anus. So perineoplasty or perineorrhaphy can be done to repair a deficient perineum and enhance sexual function. So what are the potential impacts on sexual function? So I have just before and after the pictures of labia minoroplasty. So as it can be seen that this is on the left side there is a picture of a hypertrophic labia minora and on the right side it is a picture after surgical correction. So, and the next one is a before and after vaginal tightening, a surgical vaginal tightening. So all of you can see a very gaped vaginal opening on the left side and on the right side the vaginal gaping has been corrected. So I think this diagram has been discussed throughout the conference. So this is the normal female sexual response. So when a patient is not satisfied with the appearance of her external genital organs, so basically the desire component is affected. She doesn't feel confident enough that her genitalia are attractive to the female partner, her male partner. So that is the desire component which is affected. And secondly, the excitement or the arousal component is affected when the clitoris is not stimulated or the vagina is too loose to allow proper sexual penetration and sensation. So what are the positive effects of these procedures on the sexual function? It leads to improved body image and self-esteem. It leads to increased confidence and comfort during sexual activity, and it leads to an enhanced sexual arousal and satisfaction. But also there can be negative effects and we have to admit that and deal with them. So there can be pain, discomfort or sensitivity after the surgery. There can be changes in sexual sensation or responsiveness, and unsatisfactory outcomes can result leading to dissatisfaction. So what are the factors which influence the outcomes? So one is the patient characteristics. What is the age of the patient, what is the parity and the medical history of the patient. Then what are the psychological factors and expectations. If the patient has something which is a syndrome like body dysmorphic syndrome previously, then it has to be taken in consideration. And what are her expectations? If a patient is desiring a very tight vagina, like a one finger tight vagina after surgery, so what are her expectations? Then procedure type and the technique. So which kind of labiaplasty would be suitable for a particular amount of hypertrophy or particular nature of hypertrophy, that has to be decided and mapped prior to surgery. Then surgeon's experience and skill, obviously requisite and proper amount of training is very important to provide optimal results, otherwise negative experiences can also be there. Then the post-operative care, very important, proper healing, proper post-operative instructions have to be followed after the procedure. Then the healing process and the management of complications. These procedures can lead to complications also. The most common in labia minoroplasty, for example, is the over-resection. So, and the patient adherence to instructions, of course. So now I'm just about to share few evidence-based research. So this is a paper which was published very recently in 2021. So it is a paper regarding the body image, sexual function and sexual satisfaction among couples before and after gynecological cosmetic surgery. So it was found that the female cosmetic genital surgery improved the body image. Yeah, I have to, just 2 minutes I'll write it. So impact of labiaplasty on sexuality. So this study also concluded that the labiaplasty had a positive impact on sexual functioning of the study population, and various scales like Rosenberg, self-esteem scale, FSFI, and a lot of indices which are used to measure the sexual function can be used. Then the impact of labiaplasty on sexuality. This is another very recent paper published in just 2024. So it also concluded that the labiaplasty surgery is a very safe surgical procedure. It has positive effect on women's genital self-image and sexual function. Similarly, vaginoplasty. It has dual effect on the female sexual function also and the male sexual function as well. So it leads to an improvement in the sexual function of both males and the females, and additionally significant decrease in the indices of temporary anxiety levels and the inherent predisposition for anxiety disorders after vaginoplasty. So this is a similar study, and here also satisfying outcomes were obtained after female genital cosmetic surgery. So obviously patient counseling expectations are very important, and proper informed consent is mandatory before a patient opts for any of these procedures. So female genital cosmetic surgery, to conclude with, leads to a positive effect on the sexual function and satisfaction, but further research is still needed to understand the long-term effects of these procedures. So there are obviously ethical dilemmas and legal considerations which have to be borne in mind. Thank you very much for your patient listening.
Thank you, Dr. Manvi Verma.
Now I will invite Dr. Anupama Tejuja. She is MA in Counseling Psychology, done from London, then BA in Psychology, and she is hypnotherapist, done from Thampa, and now she is consultant hypnotherapist and counselor at Kohinoor Super Specialty Clinic, Dhaka.
Good evening. I'm Anu Tejuja, and I'm here to talk about sexual hypnosis. I'm a psychologist and a hypnotherapist, and I work with a lot of people with sexual issues. I really believe there are 3 things in life which are critical, and when there's a problem with one of them, there's a problem with everything else. First is hunger, second is sleep, and third is sex. These are 3 natural instincts. No one has to tell you to feel hungry, to feel sleepy, or to feel horny. But when there's a disruption in any one of these 3, it spills over to almost everything else in life. My goal on talking about sexual and erotic hypnosis is to explain in a clear and accessible language a deeper understanding of the subject, to demystify it without trivializing it. Out in the world, one hears many extreme positions on psychotherapy and even more so on hypnotherapy. Hypnotherapists are often seen as wizards or magicians, and infrequently as what we really are, something in between. Then naturally, hypnotherapy retains its negative stigma. If you see a hypnotherapist, you must be weak, crazy, lonely, gullible. Amidst all that, how are you supposed to make informed decisions about going for hypnotherapy for yourself or someone close to you? Where can you find answers to questions like, should I go? Should my current companion and I go? Can it help? Is it worth the expense? Just what is sexual hypnosis anyway? If you're already in treatment, you may have other questions like, how do I know if it's working? How can I tell if my therapist knows what he or she is doing? When should I stop going? At its best, hypnotherapy is a medium through which the subconscious is accessed more easily. It's like a short circuit to the subconscious. When other lines of treatment come to a standstill, as sometimes things are so deeply rooted in the subconscious, is where hypnotherapy comes into play. People have infested hypnotherapy with a lot of false ideas. It's perhaps the most beautiful state that God has made valuable to mankind. And this beautiful state contains nature's own anesthesia. Sexual hypnosis refers to use of hypnotic techniques to enhance or influence sexual experiences. This can involve inducing a state of deep relaxation and heightened focus, where suggestions related to sexual arousal, intimacy, or behavior are introduced. It works by guiding someone to a trance-like state where they become more open to suggestions. In the context of sexual hypnosis, these suggestions are typically related to enhancing pleasure, improving intimacy, or addressing sexual concerns. It's important to know that hypnosis requires the subject's willingness and cannot force someone to do something without their will. Hypnosis leverages the power of suggestion and the brain's ability to focus intensely on specific ideas or images. It involves bypassing the conscious mind's critical factor to reach the subconscious, where beliefs, habits, and emotions are more malleable. When applied to sexual experiences, hypnosis can be used to reduce anxiety, increase confidence, or overcome psychological barriers that may be affecting sexual performance or enjoyment. The suggestions given during hypnosis can help reframe negative thoughts or enhance positive feelings related to intimacy. Sexual hypnosis can be effective when other treatments for sexual issues have not yet yielded the desired results. For example, in many cases of erectile dysfunction, a person who has tried many medications such as Viagra, PDE5 inhibitors, and psychological counseling for erectile dysfunction, but these treatments have not been effective. Hypnosis can be used to reduce performance anxiety, which is often a psychological component of erectile dysfunction. Through guided sessions, the individual may be trained to visualize successful sexual encounters, building confidence and reducing the mental blocks that contribute to erectile dysfunction. This can shift focus away from fear of failure to a more positive, relaxed state. A low sexual desire can be turned around. Another example is if a person experiences a decrease in sexual desire, possibly due to stress, hormonal changes, or relationship issues, and when traditional therapies like hormone treatment or relationship counseling haven't worked. Hypnosis can help by identifying and addressing subconscious beliefs or emotional blockages that may be dampening sexual desire. The hypnotic process may include suggestions that rekindle interest in sexual activities by associating them with positive emotions or experiences, helping the individual reconnect with their natural sexual drive. Overcoming trauma-related sexual difficulties. Someone who has experienced sexual trauma and has found traditional talk therapy to be insufficient in overcoming their difficulties with intimacy is often helped with hypnosis. Sexual hypnosis can provide a safe space for the person to confront and reframe traumatic memories without directly reliving them. Through hypnosis, the individual may be guided to replace feelings of fear or discomfort with a sense of safety and control. Over time, this can help them to gradually feel more comfortable with intimacy, improving sexual confidence and performance anxiety. An individual feels highly anxious about their sexual performance, leading to avoidance of sexual encounters. They have tried maybe cognitive behavioral therapy and relationship techniques, relaxation techniques without success. In hypnosis, the person might be led through visualization where they experience successful and enjoyable sexual encounters. This process can help to reprogram their mindset, making them more confident and relaxed during real-life sexual experiences, potentially overcoming the anxiety that other treatments fail to address. A person with vaginitis, involuntary muscle contractions that prevent vaginal penetration, who has not responded well to physical therapy or dilator therapy. Hypnosis may help by addressing the underlying psychological triggers of vaginitis. Through relaxation and suggestion, the individual can work on reducing the fear or tension associated with penetration, gradually releasing the muscle response and allowing for more comfortable sexual experiences. Some important considerations for sexual hypnosis. For complex cases, a complementary approach. Hypnosis is most effective when used alongside other treatments rather than a standalone cure. My framework is eclectic. I draw from a variety of therapies attuned to the specific needs of each client. I treat each person holistically and do not treat people simply in terms of their symptoms or diagnosis. The body has an innate intelligence to heal itself, and no disease can be cured without the full cooperation of the mind. I would like to end my talk today with a famous phrase by Earl Nightingale. Whatever we plant in our subconscious and nourish with repetition and emotion will one day become a reality. I hope this is cleared out some of your thoughts on hypnosis and how it might help. Thank you so much.
Now I would like to invite all the speakers on stage for felicitation.
Dr. Alithia, Dr. Manvi, and Dr. Anupama, please come on stage.
Alright. Madhumita Bahale to felicitate our chairpersons. Medal taka I would like to invite Zulkar Bhai and Mr. Tejuja on stage for a couple photographs. And Sanjay and with this, I would like to conclude the scientific sessions for day 2 and hand over the mic to Chairperson Dr. Venkatramana sir.
Congratulations both of you, Muta and Sathe, for finishing in time, 5 minutes before time. I congratulate you. That's a nice job. Very good job done. Yes. So now the tea will be served. Leave it here only. Yeah, fine. After that, we will start the AGM. AGM will start.
झालं ना काय एजीएम काय एजीएम बोला ना बस आलो बूट खोलला म्हणाला
To all the eligible doctors, the AMC certificates are available outside. You can take them.
you.